I would like to invite the zonal coordinator, Dr. Latika.
Thank you, sir. Good evening, all. It's my pleasure to introduce the speaker of the day or the lead discussant of the day, Dr. Janaki Menon, who is the professor of Government Medical College, Thrissur. And she is known to everybody. And I welcome you, madam, to this session.
Thank
you. I invite Dr. Peter P. Warren, who is Associate Professor, GMC Ernakulam, to introduce a case as well as the presenter. Thank you.
Good evening, respected senior teachers and dear colleagues. So today's case is from Government Medical College, Ernakulam, and our final year PG, Dr. Sandra, will be presenting. So, I think somebody is not muted.
Okay, please continue.
So I am very happy to introduce our final year PG, Dr. Sandra. She will be presenting the case, and madam, if madam is ready, we can proceed with the case.
Good evening, all. It's a pleasure to be on this forum to discuss a case with Sandra, who has been to a lot of trouble, who has taken a lot of trouble in preparing her case. So I think without much further ado, let's start. Sandra, you can start presenting.
Okay. Good afternoon. Presenting case of Aisha Fatima, 5-year, 7-month-old girl child from Palluruthi. Informant is the mother and history is reliable. She presented with complaints of yellowish discoloration of eyes on and off since 1 year of age, fever for 4 days and vomiting for 3 days. History of presenting complaints. Child was apparently well until 1 year of age when the mother started noticing mild yellowish discoloration of eyes on and off. It was sudden in onset, lasts for a duration of 3 to 5 days, after which it subsides spontaneously, and it was not associated with fever or drug intake. Color of urine and stools was normal at the time. At that time, there was no history of fatigue, pallor, palpitations, or breathing difficulty noticed by the mother. There was no history of failure to gain weight, no history of abdominal pain or pain in the limbs, no history of intake of indigenous medication, no history of abdominal distension noticed by mother, no history of vomiting of blood, passage of black, tarry stools or fresh blood in stools, and no history of pruritus. Currently, the child came with complaints of fever for 4 days, which was high-grade, intermittent, relieved with medication, active in the interfebrile period, not associated with chills or rigors, history of vomiting for 3 days, 4 episodes, non-projectile, non-bilious, no blood in vomitus, no history of loose stools or abdominal pain currently. There is no history of dysuria, foul-smelling urine, or increased frequency of micturition. There is no history of decreased urine output, lethargy, or decreased appetite. No history of altered sensorium or abnormal movements. No history of rash, myalgia, or arthralgia. No history of travel in the recent past or intake of food from outside. Currently, the mother has not noticed discoloration of eyes, skin, or urine. Past history. There is no history of past hospital admissions. No history of blood transfusions in the past. No history of any acute onset abdominal pain or limb pain or headache and seizures in the past. No history of abdominal surgeries in the past. Antenatal history. The first child of non-consanguineous marriage, born to a 30-year-old primary mother and a 36-year-old father. There was no history of previous abortion. It was a booked case and regular antenatal checkups were done at a private hospital. In the first trimester, folic acid was taken, injection TT was taken, first trimester scans were normal, there was no history of fever with rash, no history of spotting PV, no history of radiation exposure or any other drug intake. In the second trimester, quickening was felt at the 5th month, antenatal scans were normal, There was no history of GDM, antepartum hemorrhage, PIH, or anemia. Calcium and iron tablets were taken. In the third trimester, adequate weight gain was present during pregnancy. Antenatal scans were normal. There was no history of bleeding PV, leaking PV, or UTI. There was no history of foul-smelling liquor or high-grade fever. Birth history, the baby was born at term via LSAS in view of failed induction with a birth weight of 2.8 kg, and the baby cried soon after birth. The baby was noted to have neonatal jaundice on postnatal day 2. The mother's blood group was B positive and the baby's blood group was O positive. The baby received phototherapy for 2 days and was stopped on postnatal day 4. Maximum serum bilirubin value was not known. There was no history of blood transfusion, no history of swelling of the head, no history of abdominal distension, vomiting, or seizures, no history of abnormal body or urine smell. The color of stools and urine was normal. There was no history of any congenital anomalies noticed then. The baby was discharged after 1 week and was sucking well at breast at the time. The baby had adequate weight gain on routine follow-up after that. Development, she attained all milestones at the appropriate age. Gross motor, currently she is able to skip. Fine motor copies a triangle. Social, she helps in household tasks, dresses and undresses. Language, she has meaning of words and she is able to count till 10 and write English alphabets. Vision and hearing is normal and currently she is going to LKG. Diet history, the child was...
So can I interrupt at this point? Why was this child admitted?
The child was presented with fever and vomiting, was referred from an outside hospital because they noticed the jaundice and suspected a viral etiology. Hence, the child was referred. And diet history, the child was exclusively breastfed till 6 months and weaning started after 6 months. Diet history was taken by 24-hour dietary recall method. The diet is rich in micro and macronutrients. The child consumes green leafy vegetables and non-vegetarian food, consumes cow's milk, good exposure to sunlight. She has a calorie deficit of 254 kilocalorie and a protein deficit of 3 grams. Family history. The mother had history of fatigue, giddiness, and pallor at 14 years of age. She also had upper abdominal distension, for which she was investigated and told to have anemia, details of which she is not aware. She was also told to have gallstones and she was started on an oral medication which was discontinued by herself after 3 months. There is no history of any blood transfusion or abdominal surgeries. The mother has history of intermittent jaundice from then, lasting for a duration of 3 to 5 days. These episodes are associated with fatigue and pallor and normal color of urine.
Can I interrupt once more?
Yes, ma'am.
What treatment was taken by the mother? If she had a history of intermittent jaundice lasting for 3 to 5 days, didn't she feel this was significant with fatigue and pallor and normal color of urine and all that?
Because it subsides.
Since when has she had this intermittent jaundice?
From 14 years of age, intermittently, at least twice in a month, she has similar complaints.
But so why was any treatment taken? Was any consultation done? Where are they from?
They are from Ernakulam, but the mother was investigated initially at Kozhikode at 14 years of age. She was told to have anemia and she was informed that the disease will not progress. Hence, she has not consulted later on.
Did she need a transfusion at the time?
No, she has never required a blood transfusion.
Was she treated with iron at the time?
Mother is not aware of what exactly the medication was, but she remembers this was at 14 years of age. She remembers that she took the medication for 3 months, after which she stopped the medication.
Okay, so when she had antenatal checkup, you said it was a book pregnancy, etc. Was there anemia?
There was anemia, but the mother does not remember the doctor telling about, mother does not recall the doctor talking about anemia.
Did she need a transfusion? Did she need a transfusion?
She did not require a transfusion in this pregnancy.
Was she told that she had anemia?
Pre-existing anemia was told, but not new anemia which required specific treatment management in her pregnancy. She did not require, she was continued on the regular iron and folic acid tablet.
Were the gallstones found during the
At
during the
14
ultrasound scan, antenatal period, USG scan? Was USG done during
USG
the
was done.
antenatal period? Was
Yes,
gallstone seen at that time
gallstones were seen at that time.
during the antenatal period?
Antenatal period, yes, ma'am.
Nothing was advised. Was she investigated for the same? Is she obese?
She is not obese.
Okay. All right.
The child is the firstborn of a non-consanguineous marriage. The second child was a stillbirth. During the pregnancy of the second child during the antenatal period, however, she required one blood transfusion. The stillbirth baby expired due to severe HIE, meconium-stained amniotic fluid, but the death summary of the stillbirth reveals that that child had hepatosplenomegaly. Socio-economic status. The father studied up to 9th standard, works as an auto driver. Mother studied up to 12th standard, works as is a housewife. They have a monthly income of rupees 20,000. They belong to lower middle class according to modified Kuppaswamy scale 2023, and they are registered under RBSK scheme. Summary. A 5-year-old girl, firstborn of non-consanguineous marriage.
No.
with
Can
a
you give me your 1 second? Can you give me your impression at the end of this history? You don't need to summarize. Just give an impression.
This is a child who, with the family history of hemolytic anemia, with history of intermittent jaundice from 1 year of age.
Why do you say there's a family history of hemolytic anemia? You're
Because
not sure. There is no time. There is no diagnosis. Such a mother had recurrent jaundice. That's all you can say.
recurrent jaundice.
Which again you're not sure about because it's not documented. Was it jaundice? You're not sure.
Okay, ma'am. With a family history of intermittent jaundice, and this child has intermittent jaundice from 1 year of age, currently presented with fever for 4 days and vomiting for 3 days.
No, what's your impression?
Impression, this is most likely a hemolytic anemia, which is non-transfusion dependent, who currently presented with a viral fever, probably.
Why do you say so? Is it based on the history in the mother? Is that all?
No, ma'am. This one is the child has family. There is family history of intermittent jaundice,
which we're not very sure about. It has not been documented.
Yes, ma'am. In the neonatal period, there is history of jaundice from day 2 of life. There was no history of blood group incompatibility, and the child required phototherapy for 2 days.
Is that a prolonged neonatal jaundice?
No, ma'am. Then the child has history of intermittent jaundice in the past from 1 year of age, which has been noticed by the mother.
Okay. Why didn't she seek treatment for the same?
Because the mother also had similar complaints. She assumed that the child also had the same disease. Hence, she did not seek medical care for the same.
Does anybody have any comments to make? Does anybody else want to comment?
Sandra,
Yes, sir.
few points.
Sir, ഞാൻ സ്റ്റുഡൻസിനോട് ചോദിച്ചേ.
അത് ശരി ശരി അതെ സ്റ്റുഡൻസ്
PGs-നോട് ചോദിച്ചാ PGs എന്തെങ്കിലും ഉണ്ടോന്ന്. Do any of the PGs who are listening, are there any PGs listening? Do you have anything to say?
കൊച്ചിയിലെ PGs ഇല്ലേ? എറണാകുളത്തെ PGs ഇല്ലേ സാന്ദ്ര?
കീർത്തന ഉണ്ട് സാറേ, കീർത്തന ഉണ്ട്.
സാൻഡ്ര ഇട്ട് റാഗി ആണെന്ന് തോന്നാൻ പാടില്ല.
കീർത്തന പറയട്ടെ, ആൻസർ പറയട്ടെ.
Video also.
സാരില്ല, നമുക്ക് വിൽ കണ്ടിന്യൂ. ഓക്കെ ഓക്കെ സാൻഡ്ര, you can continue.
Examination, general examination. The child was examined in the supine position. Child was active.
Did you have any differential diagnosis? Since you said intermittent jaundice, why do you want to say it's hemolytic anemia straight away? Is it so common? Could it be Wilson's disease?
It could be Wilson's disease, but yes, yes, ma'am.
But
if the mother did not have any other, could be Wilson's disease, ma'am. It could be other differential diagnosis. It could be a chronic liver disease like Wilson's disease. Or it could be because there is intermittent jaundice, we can also suspect a surgical cause also, maybe. Because there is intermittent jaundice.
Okay.
The child was examined in supine position. Child was active, alert, and well nourished. The heart rate was pulse rate was 120 beats per minute, regular, normal volume. All peripheral pulses were felt and no radiofemoral delay. The blood pressure was 100/60 measured in the right arm. Saturation was 98. Respiratory rate was 28 breaths per minute, regular. Temperature was 101 degree Fahrenheit measured in the axilla. On head-to-foot examination, the shape and size of the head was normal. There was no hemolytic facies noted. There was no dysmorphic features. Eyes and conjunctival pallor present. The sclera lemon yellow icterus was present. No Bitot spots or subconjunctival hemorrhage. Oral cavity, tongue pallor present. Undersurface of the tongue icterus present. No angular stomatitis, cheilitis, glossitis. No petechia or thrush. Tonsils are normal. No lymphadenopathy, JVP not elevated. Bones and joints, no tenderness, deformities, swelling or restricted movements. Limbs, palm or pallor present, no edema. Nails, no clubbing, coilo or platinichia. Skin, no rash or bruising. External genitalia was normal and SMR was prepubertal. Anthropometry, weight for age was 13.2 kg, which falls between -2 to -3 standard deviation. Underweight, height for age was 98 centimeter, which falls between -2 to -3 standard deviation. Stunting, BMI was 13.7, between 25th to 50th centile, which was normal. MPH was also calculated. This is the growth chart of the child.
What's your interpretation? Why do you think? Why do you think it? What's your interpretation?
In this child has underweight and stunting. However, the child falls within the MPH. This short stature could either be attributed to the underlying disease, or it could be due to the underlying disease. But the mother also has the same disease, or it could be familial short stature.
How old is she? 5
She
years
is
old.
5 years 7 months.
What about the weight for height or the BMI?
BMI is 13.7, which is
right.
between 25th to 50th centile.
Okay.
On a systemic examination, abdominal examination, inspection, shape of the abdomen appears normal. There is no distension and flanks appear normal. Umbilicus is central and inverted. All quadrants move equally with respiration. No visible pulsations, dilated veins or scars. Skin over the abdominal wall appears normal. On palpation, abdomen was soft on palpation. There was no local rise of temperature or tenderness. Liver is palpable 4 cm below the right costal margin. Non-tender, rounded borders, firm in consistency and smooth surface. Spleen is palpable 1 cm along the splenic axis. Rounded borders, non-tender, firm in consistency and smooth surface. Splenic notch was not palpable. Percussion, the liver span was 11.5 centimeter. Trop space was dull. There was no shifting dullness. Auscultation, bowel sounds were heard. Other system examinations, higher mental functions were normal. cranial nerves were normal, motor system examination was normal, cerebellar signs were negative, gait was normal, sensory system was normal, and there were no signs of meningeal irritation. Cardiovascular system, heart sounds were normal, no murmurs. Respiratory system, vesicular breath sounds heard bilaterally, no added sounds. Examination of the parents, the mother had conjunctival pallor and icterus was also present. On per abdomen, hepatosplenomegaly was present. Father, there was no pallor, icterus or hepatosplenomegaly. Investigations.
So what's your
The
clinical diagnosis? What's your clinical impression after the examination? Does it confirm your suspicion?
Yes, ma'am. There is pallor, icterus, and hepatosplenomegaly. And there is the child is underweight, and there is
What
short.
is the reason for the hepatomegaly?
The reason for the hepatomegaly is extramedullary hematopoiesis.
What did you say the liver span was? 11.5.
11.5 centimeter.
Would there be any other reasons for hepatomegaly?
Because the child presented with fever and vomiting, there could be an ongoing viral infection together could have been there along with the underlying condition. Or if the anemia was very severe, then the hepatomegaly could have been part of congestive cardiac failure, but in this case, it is not so.
Okay. All right, you can continue. You didn't tell me the clinical impression.
Clinical impression is this is probably a case of hemolytic anemia, which is non-transfusion dependent. It could be the probable differential diagnosis are it could be
Acute hemolytic anemia or chronic hemolytic anemia?
Chronic hemolytic anemia. Chronic hemolytic anemia, non-transfusion dependent. Probable differential diagnoses are hereditary spherocytosis, enzyme defect, non-transfusion dependent thalassemia, congenital dyserythropoietic anemia.
So you have to tell us the pros and the cons. Why did you feel it's hereditary spherocytosis? Like I said, does any other PG want to say something? How many PGs are there? There seem to be quite a good number of people there. So can some other PGs who have been listening to this, would you like to say something? You need not switch on the video. You can just say, it would be nice if you switched on the video also. Just so that this doesn't turn into a back and forth kind of thing. Would you agree with her clinical diagnosis of hereditary spherocytosis as the first differential of this chronic hemolytic anemia?
Dr. Kirtana, Dr. Ajay, PGs there.
പീറ്ററിന്റെ വോയിസ് ഒന്ന് പ്രശ്നമുണ്ട്. പീറ്റർ മൈക്ക് ഒന്ന് നോക്കണേ, ക്ലിയർ ആവും.
പീറ്റർ മറ്റേ PGസിനെ വിളിച്ചതാ, അവരാരും അനങ്ങുന്നില്ല. Okay, Kirtana, can you tell me the pros and the cons? Why do you feel this is hereditary spherocytosis?
Someone has written thalassemia intermedia in the chat box.
And the child is having anemia with icterus, positive family history of jaundice, and also the child required phototherapy during the newborn period. Along with the hepatosplenomegaly present.
Okay, hepatomegaly actually not so common in hereditary spherocytosis. Usually you have an
Splenomegaly.
anemia and a mild jaundice and splenomegaly. Hepatic enlargement is not so commonly seen. Okay. And your next differential, what is your next differential, Sandra?
An enzyme defect,
Which enzyme
like-
defect are you talking
like
about?
G6PD deficiency.
Do you think this could be G6PD deficiency really?
No.
So why is it that you don't think so?
Because there is intermittent hemolysis, but the intermittent hemolysis are not associated with any infection or drug intake.
What kind of inheritance does
It has,
G6PD
and
deficiency
also
have?
it has a linked inheritance. Hence, it
So-
is not a G6PD.
It's unlikely to be, right?
Unlikely,
Because
yes.
this is a girl, right? This is a girl
Yes.
whom you have presented. Okay, then anything else? What's your
Non-transfusion
next one?
dependent, non-transfusion dependent thalassemia.
Thalassemia?
Thalassemia intermedia.
Hmm.
It could be thalassemia, but the presentation was at 1 year of age, and the icterus is intermittent and severe in this case. But the child did not require.
I'm not so sure about your severe icterus. You think any mother would just sit at home with a child with severe icterus? She would certainly reach out to somebody, right?
Yes, ma'am.
And does thalassemia have severe icterus anyway?
No, does not have
Hmm.
minimal icterus. It could be because presentation started at 1 year of age. It could have been just because it is after 6 months. It could be thalassemia intermedia as well.
As well as the presence of hepatomegaly.
Uh,
Hepatomegaly. It's not
Hepatomegaly.
usually common. It's not so common to see hepatomegaly in HS. All right.
Okay.
Thalassemia intermedia can have hepatosplenomegaly. This is a very small hepatomegaly. 11.4 is not a very big
Big.
enlargement, is it? Okay. Then what's your next differential?
Congenital dyserythropoietic anemia.
How would that present? Can somebody else say? How does it present? Is it transfusion? Don't you need repeated transfusions? In congenital dyserythropoietic anemia, generally they need a transfusion dependent anemia. It's generally a transfusion dependent anemia. Okay. Anything else? Any other differentials that you have? Nothing. Anything else? We said something about Wilson's disease. Can it present like this?
It could be a chronic liver disease. Could be Wilson's.
Why could it be Wilson's?
Because
Just agree with me. You can say no if you don't feel so, as long as you can give your reasons for that.
There is hepatomegaly, but immune hemolysis.
Can you get hemolysis in Wilson's?
There can be DCT negative immune hemolysis. DCT negative immune hemolysis can be present in this disease also.
Right. Wilson's disease is a condition with very different and atypical manifestations often, and it's not that uncommon.
Yes.
All right. Do you have any more differentials to talk about? No. So everything is spinning on your family history, right? So it becomes very important the point that comes out is that it becomes very important to examine the mother and the father for anemia, for jaundice, for hepatosplenomegaly, even if you do not get this history. Even if you do not get the history of the jaundice or pallor or transfusion in the parent, you still should examine the mother for splenomegaly when you have a child in whom you're suspecting hemolytic anemia, or even in a case of chronic liver disease. All right. All right. So shall we progress to the investigations? Does anybody have anything to say? Yeah.
Can I tell something?
Parnolo.
One thing, here the hemolytic anemia is entertained because there is echolauric jaundice. You have mentioned that the urine is clear. So when you are asked about Wilson also, in Wilson, I think the hemolytic anemia is not in the initial phase. I don't think at this early stage they can have hemolytic anemia. And if at all you think that jaundice is due to Wilson, you should see the urine to be colored. So that is one thing. And you agreed to Madam saying that it could be Wilson, even after knowing that mother also is probably having a similar condition. You know that Wilson is autosomal recessive condition. So both mother and daughter unlikely to have the same condition. Okay. So another thing is regarding J6PD deficiency. Girls can also have J6PD deficiency, but there is no this hemoglobin feature suggestive of hemoglobinuria in this case. So that you should have mentioned. Then, even though this child is not having hemolytic facies, I think you should have mentioned whether mother is having hemolytic facies or not, because she has suffered from this problem for a longer period. So more chance that the mother could have hemolytic facies, that you could have mentioned whether it is there or not. Then in hemolytic anemia, usually splenohepatomegaly is expected rather than that already mentioned. So in this case, when you are identifying that there is hepatomegaly, you should have mentioned what is the consistency of liver. What was the consistency you mentioned?
Firm in consistency.
Firm. Okay. So if it is soft in consistency, it could be due to the acute problem child is having, probably due to a viral infection. If it is firm, definitely you should think that it is a chronic problem.
Rounded borders എന്ന് പറയുമ്പോൾ പലപ്പോഴും firm അല്ലല്ലോ. Margins are usually well defined and sharp and firm hepatomegaly. If the margins are rounded.
And the present fever and vomiting, I think you could have mentioned more details about that, how sick child was, whether there is loss of appetite, because now there is an outbreak of hepatitis all over Kerala, I think. So whether it could be a viral hepatitis still in a child already having some other problem, that also has to be considered when you are getting a hepatomegaly like this. Okay.
പുരുഷോത്തമൻ സാർ രണ്ട് വാക്ക് പറയണോ?
Sandra, in the history, what is the educational status of the parents? It's very important here because in the present context in Kerala, especially in Cochin, a 14-year-old girl diagnosed to have some problem, asked to take some medicine, and she doesn't remember the things, and she had been going through the pregnancy and the second pregnancy and all. It's a bit unusual for such a situation. What about her IQ and what about her education standard?
12th
Mother
standard.
12th standard. Father has studied up to 9th standard.
9th standard. So very, very unusual, because those things they'll be concerned, especially when they are going for a pregnancy, going to have a baby and all. Definitely they should be knowing. That is one thing. Then another, why didn't you draw the pedigree chart? No, all the situations.
വരച്ചിട്ടുണ്ട് സർ.
ഉണ്ടായിരുന്നോ?
വരച്ചിട്ടുണ്ട്.
3 generations. The pedigree chart concession, you should be drawing that also. First generation, second generation, because in this case, mother is affected, the baby, 2 kids, most likely the fetus. That is very important in that case. The second pregnancy is more important because she needed a transfusion. There was a baby loss, which was documented to have a hepatosplenomegaly. So in that situation, it's a most likely vertical situation itself, and there the grandparents level, the first generation also is important. Pedigree, you need to, was there any other loss or anything in that generation? Because we are very likely to ignore that previous generation. In this case, the previous generation analysis is important. The beginning itself, the first point is urine is not colored, eyes are colored. and always associated with fever and stress. So initial part of the history, definitely there were two differential diagnoses, Gilbert-Barre hemolytic anemia. But the episodic parallel situation comes, and especially when you get the mother history, the points are more and more for a hemolytic situation.
Including the gallstones.
Including, definitely, including the
gallstones.
So,
hemolytic anemia normal color
Sorry, ma'am.
dark color.
Hello. Hafsa, if you want to ask, you can unmute and put on your video and ask. All right. Parnolu, sir.
Okay. And that's where do we stop? In the history analysis, the
parental history.
More in favor of hemolytic situation. Then comes the other analysis situation. The mother had episodes transient pallor. Only one very stress situation, he needed a transfusion. He's surviving up to this age, above 35, without much of problems. That's the point. So any problem which allow her to survive without transfusion, only one transfusion during such a stress situation. So that is a clue for type of the hemolytic disorder. What are the possibilities? As you rightly said, one possibility is a erythrocytosis, another is a non-transfusion dependent hemolytic anemia. There is a possibility of some rarer other situations also. You need to keep a wider possibilities. The other clue is the onset of the illness. The onset of the illness in the neonatal jaundice, should we consider that a condition presenting from the newborn period or later? Because beta chain disorders are out. If you think it didn't present in the antenatal period or in the neonatal period, it started only after 4 months. Okay, so beta chain disorder.
No, in this patient, the jaundice did not seem to be very significant, was it? Or why was the child there for 1 week in the ICU? The jaundice, prolonged jaundice or not? That's what we want to know.
The jaundice started on day 2, required phototherapy for 2 days, but the baby was discharged along with the mother. The mother was kept for the admission procedure went on for that many days because the mother underwent an LSCS. For mother's sake, the baby was kept.
Okay. Shall we proceed, Sir Ningam?
Okay.
Investigations. How would you plan the investigations? Would you just say what your plan would be before you start talking about what you got?
Because the first differential diagnosis, the diagnosis we are suspecting is a hemolytic anemia.
No, what about her acute? What about the short febrile illness?
The short febrile illness also, it
What
could
did
be
you
a
think it
viral
was?
fever. A viral fever.
So when you saw this child first with this fever and jaundice and spleen and liver, did you think of viral fever straight away? Or did you think of HS straight away? What did you think of?
Initially, I thought of viral hepatitis.
And then as you went into details with the history and so on, you thought there was something more to it.
Once I saw the mother, I thought there was something more to it.
Okay.
You will first do a CBC, a complete blood count. The complete blood count, you will look at the hemoglobin to see the degree of anemia. Then you will look at the total count to see to look for evidence of infection. The differential count, the platelet count. In this case, HB was 8.4. Total count was 16,550. It was a neutrophilic. Platelet was 4.52 lakh. Then we look at the red cell indices. MCV was 79.2. It is just below normal. MCH was 27.7, below normal. MCHC was 34.9, on the higher side. RDW was 19.7, which is high. Hematocrit was 24.2. The retic count was 3.4%. Corrected retic count was 2.4%. And serum iron was 25, serum ferritin was 187, TIBC was 259, and transferrin saturation was 9%.
Why did you do all those straight away?
To rule out other causes of the anemia.
How about a peripheral smear?
Peripheral smear
Straight
was
away.
done.
Mm.
Peripheral smear showed numerous spherocytes and polychromasia and neutrophilic leukocytosis.
Sandra, will you go back to the previous slide? We should be making use of the, when the investigation, definitely there's a neutrophilic leukocytosis. It may or may not be related to the present condition. Okay. Hemoglobin is low. Okay. Hemoglobin for that age, it is on lower side. MCV, you said that it is just less than. So what is the MCV, normal MCV?
80.
No. What is the MCV? 80, it comes up at around 10 years only. So we need to know the cutoff of the MCV, both the lower and the upper ones. It's age based. Okay. So 79 is not a low volume MCV for that 5-year-old child. So what is the normal low MC, volume lower cutoff for the age you need to know? And one important thing is we should be utilizing the RDW and all. Okay. So
Yes,
because
sir.
there can be a combination or all the other possibilities in the index also. RDW, what's your comment, RDW?
RDW is high. RDW is an
It's
indicator.
high. Are you expecting
residency?
If
Residency.
RDW can be high in case of hereditary spherocytosis.
സംസാരിക്കുന്ന ആൾക്കാർ ആരാണെന്നറിയില്ല. ഒന്നുകിൽ ആവശ്യമില്ലാത്ത ആൾക്കാരാണെങ്കിൽ ക്ലാസ് വിട്ട് പോകണം. ഇങ്ങനത്തെ കാര്യത്തിന് വന്ന് ശല്യപ്പെടുത്തരുത്. PGs ആണെങ്കിലും ആരാണെങ്കിലും വേണ്ടില്ല. ഇത് എന്തിനാ ഇത്രയുള്ള കാര്യങ്ങൾ സ്പോയിൽ ചെയ്യാൻ വേണ്ടി വരുന്നത്? ഒന്നുകിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്യുക, അല്ലെങ്കിൽ ഡീസെന്റ് ആയിട്ട് ഇരിക്കുക. ഒരു ഇൻഡീസെൻസി എന്നുള്ള കാര്യത്തിൽ കൂടി പോസ്റ്റ് ഗ്രാജുവേറ്റ്സിനും എല്ലാവർക്കും പറഞ്ഞിരിക്കുന്ന കാര്യങ്ങളാണ്. എന്താ ഇങ്ങനെയായി പോകുന്നത്? ജാനകി, go ahead.
Okay, give your interpretation of the CBC and show the peripheral smear and talk about the peripheral smear.
MCV is normal. MCHC is on the highest side, and RDW is 19.7, which is high. RDW is a measure of anisocoagulophytosis. It could be because of the increased retic count and spherocytes in the smear.
Right, possible.
One more point is the
you discuss
MCHC
this
is
with
also
your
useful.
pathologist.
Sandra, one more point. MCHC is a useful index in the in this because a little higher side MCHC. So that is again arguing for a spherocytosis. So certain important clues here. MCV is normal. There is an increase in the RDW. Maybe a combination. It's arguing for this because in a case of thalassemia or whatever, when the RDW is high, which you don't expect, you are justified in assessing the ferritin and giving an iron treatment. Otherwise, it is not justified. So there is a possibility of a mixed picture. So it need not be arguing for one thing, but there can be a combination. MCHC high is a point arguing for spherocytosis in this context.
Yes.
Go ahead.
The peripheral smear shows numerous spherocytes in polychromasia. There was neutrophilic leukocytosis and platelet count was adequate. The red arrow is pointing to a spherocyte and the blue arrow to polychromasia.
To the reticulocyte.
Reticulocyte.
Okay.
Other biochemical.
So in this situation, do you really need to do the iron studies? Quite evident, right? Your peripheral smear is quite evident, right? The diagnosis is quite evident. All right. Did you do a DCT?
DCT was done, ma'am. DCT was negative.
All right.
Serum bilirubin was 4.5. Direct fraction was 1.2. LDH was 233. Viral markers were negative. USG abdomen showed gallbladder sludge.
Was osmotic fragility done now? Right.
Yes, ma'am.
Mm.
Osmotic fragility was done. The picture on top depicts the control test tubes and the picture down shows the test. In the control test tube, hemolysis occurs at 0.4% of sodium chloride, and in the test solution, hemolysis has occurred at 0.5%. In our hospital, there is no facility for spectrophotometer. Hence, graph osmotic fragility curve was not plotted. This, however, was the graph plotted for the mother at 14 years of age.
Okay, so you were able to get her reports.
ഒന്ന് കാണിക്കാവോ സാന്ദ്ര എന്തായിരുന്നു അതിന്റെ പടം ഒന്ന് എക്സ്പ്ലെയിൻ ചെയ്തേ
Were you able to get the reports? You said you weren't able to get the reports at 14 years. The mother did not know, etc.
No, mother was not aware. Mother is not aware of what condition she has. However, she has all the reports for her with her.
But the reports were with her.
With her, she is only aware that she has an anemia, but not aware of the details of the anemia.
Then describe what you saw.
In the first, there were multiple test tubes were taken. So one minute, sir, can I plug in my computer?
And the concentrations clear ആവുന്നില്ല ചോദിച്ചത്. മൊബൈലിന്റെ മുകളിലാന്ന് തോന്നല്ലേ, അതാണ് കാണാൻ പറ്റാത്തത്.
അയാളുടെ ചാർജ് പോണതായിരിക്കും.
ഓ
എന്താ സാറിനെ കാണണില്ലേ?
അല്ല, ഞാൻ എഴുതിയതൊന്നും കാണുന്നില്ല. ഞാൻ ചോദിച്ചു അപ്പൊ പറഞ്ഞത് മേലെ താഴത്തെ എനിക്ക് ക്ലിയർ ആയില്ല എന്ന് ചോദിച്ചു.
In sodium chloride was taken in serial dilutions from 0.75. Normally, RBCs lies at 0.35 to 0.45. The above test tubes show the control test tubes, and the below ones are the test tubes. In the above one, hemolysis has occurred at 0.4, which is normal, which is the normal level at which RBCs lies. In our test tube, the RBCs started lysing at 0.5. That is at a higher constant. That is at a more hypertonic saline concentration. This is because the spherocytes have a decreased surface area to volume ratio. So there is not more space for the fluid to go in. Hence, they undergo hemolysis quicker.
Okay.
Was it an incubated osmotic fragility or just?
This was not an incubated one. This was not an incubated one. This is the osmotic fragility curve of the mother.
Why do you need to incubate?
Sorry, ma'am.
Why do you need to incubate? Why do they say that incubated osmotic fragility should also be done? You said specifically it wasn't an incubated osmotic fragility, right?
Not sure.
That's because sometimes you get a false negative report without incubation. So incubation ensures that the test is valid. And are there any other tests that you know of? Because this is actually not an easy diagnosis to make.
Fragility, the difference between normal and abnormal becomes more
evident.
clear.
More evident.
Okay. On incubate. Other tests are EMA test.
Because HS, suppose you did not have this family history.
Okay, ma'am.
It would not have been so easy to make this diagnosis, right?
Yes, ma'am.
And sometimes the peripheral smear too may not be always evident. Now, this child had an acute illness and therefore you see a lot of spherocytes. But suppose the child had come later, you may not pick it up, right? You may not get the spherocytes on the smear. And sometimes this may be complex because of the infection. You may think of, this is my experience, recent experience of a child who had a pneumonia, and there was a lot of agglutination on the smear, and people were very definite that this was an immune-mediated autoimmune hemolytic anemia. DCT was negative. Other immune tests were negative. But the pathologist was not able to really say that this was hereditary spherocytosis, because you get a positive osmotic fragility even in an infection-mediated immune hemolysis. All right. So in that case, you need to have a better test, and that is where your flow cytometry, the test you just said, the eosin 5-malimide flow cytometry test. That gives you a definite diagnosis. Is it done anywhere? It's done in Amrita. All right. So it can be done in cases of when you're in doubt, when the pathologist is in doubt.
Okay.
Because the treatment is it changes with the diagnosis, right?
Yes, ma'am.
The treatment and the prognosis. All right, continue.
The diagnosis: hemolytic anemia, probably moderate hereditary spherocytosis with no evidence of crisis or congestive heart failure. Child is underweight, short stature due to chronic anemia or familial viral fever.
Would you like to elaborate on what is mild, moderate, and severe?
Mild, moderate, and severe hereditary spherocytosis based on the hemoglobin and the retic count and the SBR count. So mild hereditary spherocytosis, the HB is usually between 10.5 to 15. In moderate, it is between 8.5 to 10. And in severe, it is less than 8. The retic count is usually between up to 2% in mild, 3 to 6% in moderate, and more than 6% in severe. The bilirubin level is usually between up to the retic. This is the serum bilirubin. The retic count. The retic count is usually between. Retic count is. It is very high in severe hemolysis, in severe spherocytosis, whereas it is around 1 to 2% in mild hereditary spherocytosis.
All right. So if a child comes with an acute episode, can you decide on the basis of that whether this is mild or moderate or severe?
Cannot. You can classify between severe based on the severe hereditary spherocytosis might have a transfusion dependency history, and
right.
moderate
so the clinical, the story of the child too is important when you classify mild, moderate, and severe, right? Depending on the transfusions, need for transfusions, and the occurrence of crisis, different crises. You said no evidence of crisis. Can you also say which kind of crisis? Because we generally talk about crisis in sickle cell disease, right? Usually, but it does happen in all kinds of anemia.
The type of crisis in hereditary spherocytosis are aplastic crisis, hypoplastic crisis, megaloblastic crisis, and rarely splenic sequestration crisis also.
Can you get skin ulcers and all that?
Skin ulcers can be present in hereditary
that's what the book says. We have not seen. Probably people with lots of experience do see. Because those are usually mentioned with sickle cell disease, right? But they say that some conditions, some severe cases of HS can also present in the same way. Why does a patient have megaloblastic crisis? What can you do to prevent it?
Due to folate deficiency, so you should start the patient on folic acid 1 to 5 milligrams daily.
Lifelong.
Lifelong.
Right? All right. What did you do for your child?
This child was evaluated. The parents were counseled about the condition of the child. The parents were informed that that there is a chance of risk for crisis in the future, and the child will need at least yearly hematological evaluation to assess for the hemoglobin level. And the child was advised to be kept under for growth monitoring. Immunization was advised for the child, especially pneumococcal vaccination, which was not taken by the child, was given to the child post-discharge. Then the child was screened for gallstones, but it showed no evidence of gallstones, hence was advised to yearly screen for the same.
All right, Sandra, can you just very quickly give the presentation that from the history and presentation, how you would differentiate between the different types of hemolytic anemia, whether it's congenital or acquired, and among the congenital, what are the different ways? From the history, how do you make out?
From history, you will get a history of hemolytic anemia, that is acholiuric urine and stools will be normal, and jaundice. From that, if it is based on the age of presentation, if the age of presentation is within the within 24 to 24 hours, it could either be hemolytic disease of the newborn due to RH or ABO incompatibility. It could be hereditary spherocytosis. It could be an enzyme deficiency like G6PD or pyruvate kinase deficiency. And if it then if it presents after 6 months of age, it is most
How
likely
about hydrops?
It could also be alpha thalassemia, homozygous alpha thalassemia, and hydrops if there is mutation of all 4 genes. In after 6 months of age, it could be a globin chain defect, likely to be a thalassemia. Sickle cell anemia could also start presenting from 6 months of age. Other hemolytic anemia, autoimmune hemolytic anemias, start presenting at an older age group. Then in case of acquired conditions, there will be history of an infection preceding the condition, or there could be an underlying like prosthetic heart valve, or a condition like bite in case of acquired hemolysis.
Anything else? Acquired hemolysis.
Burns.
Anything else? Microangiopathic hemolytic anemia.
TTP, HUS. There could burns is a cause of acquired hemolysis.
How does HUS present?
HUS presents with a past history of diarrhea, after which they will have renal kidney injury, hemolysis.
What is the presentation? The child with diarrhea or some infection?
Infection after 2 to 3 weeks will present with history of
abdomen. 2 to 3 weeks. Soon after. And the presentation is usually a sick child with pallor and multiple bleeds. Okay, and very mild jaundice. Okay, so it's a sick child, unlike your HS, who is usually not so very sick.
Yes. Then from
okay, how about SLE? When would you think of SLE? Would it be SLE? Would this child have SLE?
An older girl child around adolescent age group.
Need not be adolescents.
Present it.
So, what else will you look for?
You will look for other associated findings like cutaneous manifestations.
Right. Suppose none of them have started. This is the first presentation of SLE. Would it be?
Joint manifestation like arthralgia, arthritis.
Okay, so suppose none of these are absent. All these are absent. These other findings are absent. Would this be the first presentation of SLE? Let's forget about the maternal history. Should you think about it? You should think about it. All right. So these are things these are rare things, but if you don't keep them, because hemolytic anemia itself is rare, it's not common, right? And another thing which we forgot to say is malaria.
Malaria infection.
Malaria, because we were going on about chronic hemolytic anemia. But always remember malaria, never forget malaria. And particularly in these days when we have so much of movement up and down, right? People go up and down from state to state. So she need not have gone, but she may be staying next to somebody who has traveled, or she may be staying next to migrant laborers somewhere near their places. All right, so never forget malaria when you have a child who has fever, anemia, jaundice, splenomegaly. When that patient first comes to you, not just viral hepatitis, but also think of malaria.
Okay, ma'am.
Do you have any more slides?
No, ma'am. This is the last.
സാറുമാർക്ക് എന്തെങ്കിലും പറയാനുണ്ടോ? സാറുമാർക്കും മാഡംസിനും, സുഷ്മ മാഡം, ഡാളി മാഡം.
Sushma madam, screen on off for you, Sandra.
ഒരു പോയിന്റ് initially when we were mentioning about the CVS, you should have mentioned about the position of the apex beat, because a long-standing anemia can have cardiomegaly. You have mentioned about the heart sounds, murmur and all, but the position of the apex was not mentioned. And regarding that familial short stature, what was the height of mother?
Height of the mother was 139 centimeter.
Okay, so how will you explain that?
It could be because of the chronic anemia.
So when two members are having the same disease, and that is affecting the growth, you should not entertain it as familial short stature.
Yes, short stature.
And usually in familial short stature, both parents contribute to the short stature. Here, the short stature in this girl is mainly because the mother is also having the same, and it is because of the underlying problem, basically. So here I don't think you can entertain the diagnosis of familial short stature. Suppose a person with achondroplasia and giving birth to a child with achondroplasia, and on an average the mid-parental height will be low, but you cannot call it as familial short stature.
Yes.
Okay.
You also need to remember that there are other associations with spherocytosis or acanthocytosis. And variants of spherocytosis can also have acanthocytosis. All right.
Okay.
So these can be associated with distal RTA. That's one association which is not as uncommon as we think. Spherocytosis with distal RTA.
Okay.
A continuation of what Amanda said. In the clinical presentation of all these cases, don't forget the cardiac thing. Just moving on with first and second heart sound normal. So you need to consider what you expect in a case like this. So cardiomegaly is more important. Is there a JVP, venous hum, and third heart sound, other sound changes of anemia? It's very important. Whether you are on chelating agents or whether the transfusion is high or not, all these points are important. And regarding the height, there is one more important point. You are saying that the disease is responsible, two possibilities, whether it is familial short stature or is the chronic anemia responsible for the short stature. In that state, there can be an argument. There is a treatment for complete treatment for one of these hemolytic anemia, that is spherocytosis, that is lasting relief with the splenectomy. You are not going for that because the requirement of transfusion is low. Once in a while only the hemolysis occurs. But if you account the growth failure for the NDT, there is a question that will you get benefit for the growth if you go ahead with the splenectomy? So splenectomy may be beneficial. There again, you need to consider other point of argument is when you are going for a splenectomy, it's for a lifelong risk of infections. You need to continue for the drugs and all those sort of things. So there can be an argument if it is due to chronic hemolysis, you need to. So again, the bone age part and other things also is important, because before attributing it to is it due to familial short stature or the other things, the differential things are important. And regarding that pregnancy, the loss and all, that would have been a point of discussion, because whether that loss of that baby is attributable or explainable with the spherocytosis, a bit unusual for a membrane defect to have an onset of hemolysis in utero. So whether
This was
that
meconium aspiration, sir.
Meconium aspiration,
Meconium
severe
aspiration.
pressure.
okay, but there was a hepatosplenomegaly documented in the postmortem and all. So that is a possibility. Whether
Postmortem ചെയ്തിരുന്നില്ല.
അങ്ങനല്ലേ പറഞ്ഞു?
ക്ലിനിക്കൽ നോട്ട്
അല്ല,
അല്ലേ പറഞ്ഞത്?
Death summary.
Clinical
Death
note.
summary.
അതിനകത്തുണ്ടായിരുന്നു എന്നാ പറഞ്ഞു.
ആ.
മൾട്ടിപ്പിൾ ലിവർ ആൻഡ് സ്പ്ലീൻ ഉണ്ടായിരുന്നു.
Death summary.
സമ്മറി അതാണ് ചെറിയൊരു കാര്യം അവിടെ നിൽക്കുന്നുണ്ട്. പക്ഷേ ഡോക്യുമെന്റ് എടുത്തെങ്കിൽ ഈ കേസിന്റെ അകത്ത് ഈ ടെസ്റ്റ് മാത്രമാണോ ചെയ്തത് അതോ ജനറ്റിക് ടെസ്റ്റുകൾ ചെയ്തിട്ടുണ്ടോ? കൺഫർമേഷൻ?
No, genetic test was not done.
Anyway, spirocytosis is most likely thing, അല്ലേ?
You could talk about the inheritance also, because these are things which will be discussed. Inheritance,
Yes,
autosomal. Is the penetrance the same? Is the manifestation the same? Is it similar in the mother and the child, or is it different? Because it can differ from person to person in the same family, right? Particularly HS. HS has varying penetrance.
Yes, ma'am. Hereditary spherocytosis, 75% is autosomal dominant, 25% is autosomal recessive, and sometimes there can be de novo mutations also in case of hereditary spherocytosis.
In this case, there is no need to consider de novo because this is a strong family history, mother affected situation. So, Dase, what about the genetic part? Whether they were willing for a desirous for another child, shouldn't we have a probability diagnosis?
Generally, this is an eminently manageable condition. So it is not ethical to diagnose this condition prenatally and terminate an affected fetus. So I don't think you do a genetic test and prenatal diagnosis in conditions where you can treat well. So that is one thing.
That's a one very important point.
Ethical dilemmas. I don't know what to do.
Right. അതാണ് കാരണം അപ്പം more and more of this change in the things are there, because after all this thing, our plan is to eliminate the baby. When there is more and more chance of saving the baby, there is a treatment should be go ahead. അപ്പോൾ ethical issue അതിൻ്റെ അകത്ത് വരുന്നുണ്ട്. ഇതാണ് നല്ല കാര്യമാണ്. Non-transition dependent anemia and all, there will be more and more discussions nowadays. Hydroxyurea is a treatment now offered for this, not only the sickle cell situations. Previously, we were giving it for sickle cell. They are being given non-transfusion dependent in thalassemia cases also. Calicut കൊടുക്കാറുണ്ടോ സൈപ്പോ?
ഏത് സാറേ?
And non-transition dependent anemia case also, hydroxyurea കൊടുക്കാം.
കണ്ടിട്ടില്ല.
ഉണ്ട് ഇപ്പം പുതിയ കാര്യങ്ങളൊക്കെ വരുന്നുണ്ട്. നോൺ ട്രാൻസ്ഫ്യൂഷൻ ഡിപ്പെൻഡന്റ് തലസീമിയക്കും ഇറ്റ്സ് നോട്ട് ഫോർ സിക്കിൾ സെൽ അനീമിയ ഓൺലി. ആ കേസിന്റെ അകത്ത് ലോങ്ങർ ഡ്യൂറേഷൻ പുതിയ കുറെ കാര്യങ്ങൾ വരുന്നുണ്ട് അതിന്റെ അകത്തൊക്കെ.
Sandra, you have done investigations to rule out iron deficiency anemia.
Yes, sir.
So have you ruled out iron deficiency anemia, or that is again is a possibility because the investigation showed
the transfer saturation was also low.
So is there iron deficiency also? Can they coexist?
It can coexist.
ഈ ഫെറിറ്റിൻ വാല്യൂ കുറവാന്നല്ലേ കണ്ടത്?
കുറവായിരുന്നു.
RDW is 19.5. Okay. So you need to know the cutoff of all these things there. So what is the cutoff of RDW? MCV ഞാൻ പറഞ്ഞു മനസ്സിലായോ? Lower cutoff and upper cutoff are age dependent. RDW normal value നോക്കണം മനസ്സിലായോ? That is I think it is 13 or 14 14. So anything above 14 RDW is there. So RDW is wider and ferritin level is 25 or so. So
why did you do iron studies in the first place? What is the reason for that?
Coexistence of sickle cell anemia and iron deficiency anemia, but spherocytosis and iron deficiency coexisting, I don't know whether it's possible.
Nutrition atra nalladalla alle. The diet wasn't adequate.
Said that most percentage of iron will be absorbed in.
But I wanted to know why you did it in the first place. What is the reason for that? When you had this good history and you had this document, the mother's osmotic fragility test, and the patient was so evidently a hemolytic anemia, what was the indication? There must have been some indication. Were they widow? It's an expensive test.
Initially, the reports were not available, but
the peripheral smear was very clear on it, right, with reticulocytes. It's a very nice peripheral smear that you put up.
When you showed that fragility test tube, I was reminded of the olden days when we were preparing the solutions of different strength. The present generation of postgraduates are not aware of all these things because they are on just sending the investigations to the pathology. Bedside lab, there is no bedside lab. We had these test tubes and we were preparing with a method of dropping. We take a syringe containing normal saline, another syringe containing distilled water. In the 10 test tube, first test tube, you put maybe 40 or 20 drop of normal saline. Okay. In the next one, you put, if it is 40, you reduce by 4. 36 drops of normal saline. In the next one, 2 drops. So 1/10 you are reducing. If you are taking 20 drops, next one 18 drops, next one 16 drops, like that. And in the reverse order, you drop water. Okay. 40 drops of normal saline, then 36 drops of normal saline with 4 drops of water, then 32 drops of normal saline with 8 drops of water, like that you reduce. You are preparing the solution. The first one contains 0.9. The next one is 1/10 less, that is 0.81. The third one is 0.72. The fourth one is 0.63. Fifth one is 0.63 in the 9 course 5.4. And the next one is 0.45. Like that. That is the method of bedside preparation of gradient osmotic solution. And after that, you put 1 drop of blood in each of these things. Okay. You said it starts from 4.5 and it stops at. So how can you say it is starting or completed? Hemolysis, if it is not starting, it will only go as a button to the.
Yes, sir.
It won't be lysing. The moment it starts lysing, the supernatant fluid will have a color. The starting of the color is the starting of hemolysis. Once it is completed, the entire thing is red. So that is the point of completion. That's how you decide about this osmotic fragility increase or decrease. The other one, actually, incubated fragility should be done with or without glucose. Incubated fragility increased and it is corrected with the glucose. 25% solution drops, that will be corrected. So you should be doing it with a control, normal control with the glucose, without glucose, incubation before and after that. Okay. So all these things were done earlier, but nowadays the things is not need. The new test, the flow cytometry, fluorescent test. What is the name of that, Janaki?
EMA. Flow cytometry with EMA. Used in
that is a very simple, fast. You can do it because without waiting for the genetic analysis.
It's 2,500 rupees or 3,000 rupees.
But it's worth it.
It is done at Amrita. It will give you a final diagnosis.
Specific
Specific.
In this case, folic acid that mother
mother was also given folic acid. Child was also started on folic acid.
In the plan for the management, what will be your plan for the management for this girl child and all? All the growth monitoring should be done, and hemoglobin should be done, and the associated deficiency, especially folic acid, other things should be done. Then ultrasound annually may be needed because of the gallstone. This is another possibility. Okay. Yes. Suppose they develop a case of jaundice with the urine discoloration, what will you consider?
As in child. Intravascular.
Jaundice worsens and urine coloration of yellow.
Urine becomes dark.
Urine dark. Meaning there is yellow. Yellow. There could be a coexisting there could be a coexisting viral infection along with it.
You just talked about the gallstones and things.
Uh,
What? Polylithiasis.
Cholelithiasis could cause obstruction
Jaundice.
and then
Obstructive
cause
jaundice.
urine.
High-colored urine.
Mm.
And worsening of jaundice.
In all cases of hemolytic anemias, this situation you need to consider. In a case where the patient is on drug, in a patient where he's on transfusion therapy, there are multiple reasons for urine discoloration jaundice also. It may not always be hemolytic jaundice. That can occur due to transfusion dependent, transfusion causing hepatitis. Different agents. Hepatitis B is not the only one. Transfusion transmitted hepatitis are all possible. The other one is the liver injury due to the high ferritin hemochromatosis. Okay. So there are multiple other reasons which are very well known in the case of all these chronic hemolytic disorders. Management, prognosis, everything changes. Okay.
Chandra, what is the difference in response to splenectomy in spherocytosis and thalassemia?
In hereditary spherocytosis, if there is only frequent crisis, splenectomy is done.
I'm asking what is the response? How effective?
There is improvement in growth drastically.
Same response in both or any difference?
It will be better in case of hereditary spherocytosis than in case of thalassemia, because
it cures that the person will not require transfusion in spherocytosis after splenectomy. As response is not that good in thalassemia. What will happen to the spherocytes? Will it disappear or persist?
If the splenectomy is complete, then splenectomy.
What happens to the spherocytes? Do they go away?
No, spherocytes are still there. However, the trapping of the spherocytes in the spleen does not occur post splenectomy.
What new finding will appear in the peripheral smear?
There will be Howell-Jolly bodies on the peripheral smear.
Anything else? Any other count?
Any other?
Does anything else happen in the peripheral smear? Does any to the other cell lines?
What are the hematological manifestations of splenectomy? It's not just one word answer. What are they?
The other cell lines. Platelet count?
There will be thrombocytosis.
Thrombocytosis. Platelet count will go high. Okay. RBC. Within the RBC, this changes will be there. About this. Okay. Rare hemolytic anemias can be the with HBH and all, where this whole jolly bodies are more common. So when a case like this, when you're getting an MCHC, what are the other situations where you get a spherocytes? Madam was discussing. Okay. Spherocytes are not only for this thing. HS. Yes. What are the other situations where you get spherocytes in the peripheral? Suppose you are shown the peripheral smear only.
It can be there in immune or hemolytic anemia. It can be there post-transfusion related hemolysis. In case of congenital dyserythropoietic anemia type 2, burns, clostridial sepsis, post snake bite or wasp or bee bite envenomation, in severe hyperphosphatemia. There is hemolytic disease of newborn, in thermal injury.
Many conditions, many of them are macrocytes, hypothyroidism, liver disorders, alcoholism, all these things, macrocytes actually. Spirocytes, basically in autoimmune hemolytic anemia and all. There, what the indices will be helpful? I mean, the automation.
CHC will be higher side for
MCV.
will be
What will
normal.
be the MCV in the case of hereditary spherocytosis and the other situations?
In hereditary spherocytosis, it will be either normal or low.
Low, microspherocytes. Okay. The other one usually on the higher side. Okay. What is the situation where you are getting an MCV in 150, 160 in such a case of hemolytic anemia? You are doing it. You are waiting for the result, and the result came as MCV 156.
In case of if it is a megaloblastic anemia with hemolysis, later you can get an MCV.
No.
If
So MCV you usually get in a case of a large cell, somewhere around maybe 106, 102, like that. Okay. So here is a situation where you are getting an MCV 150. So what will you consider? Is it a mistake? Definitely you consider it as a mistake, but consistently it is coming. What is the condition you consider? That is due to, that is an argument for autoimmune, because it's a machine giving a wrong value of a clumped RBC as a one cell. Okay.
Yes, sir.
Simple. One of the differential diagnosis in this case is autoimmune. So if you are getting such a MCV value, you need to consider this clumping. Okay.
Yes.
Virendra Kumar is there, silent. Any comments? Virendra ഉണ്ടല്ലോ ഇവിടെ. Anybody else seniors ആരെങ്കിലും ഉണ്ടോ? ഡോക്ടർ ലതിക?
ഇല്ല, എല്ലാം ഡിസ്കസ് ചെയ്തല്ലോ സർ. കേൾക്കണ്ടോ എല്ലാം? ഇതൊരു എനിക്ക് പുതിയ അല്ല അങ്ങനെയല്ല, ഈ MCVയുടെ ഞാൻ ഇതുവരെ ആലോചിക്കാത്തൊരു കാര്യമായിരുന്നു.
Janaki, can we wind up? That's it.
Can wind up, sir.
Okay.
Latika, the thanks for.
So I take this opportunity to thank Sandra for her very lucid presentation, Dr. Peter for mentoring her, and all the faculty of GMC Ernakulam for helping Sandra to present this case and also the patients. And I thank Dr. Janaki for being the lead discussant in this case, and all contributors to this presentation, Dr. Purushottam sir, Mohandas sir, and everybody, and all the students and other faculty who have attended the program. Thank you all.
Sandra, നന്നായിട്ട് പ്രസന്റ് ചെയ്തിരുന്നു കേട്ടോ സന്ദ്ര. സന്ദ്ര പക്ഷെ ആൻസർ പറയുമ്പോൾ മാത്രം സ്റ്റാറിങ് ആയി പോകുന്നത്, കുറച്ച് ഗ്യാപ്പ് വേണ്ട. പ്രസന്റേഷൻ നന്നായിരുന്നു കേട്ടാ. പിന്നെ ആരാന്നറിയില്ല, ഞാൻ ചീത്ത പറഞ്ഞ ആള്, ഞാൻ ചീത്ത പറഞ്ഞത് ഇപ്പോഴും ചീത്തയായിട്ട് തന്നെ നിൽക്കുന്നു. ഇവിടെ വരുന്ന ആൾക്കാർ ഇൻട്രസ്റ്റോട് നിൽക്കാത്ത ആൾക്കാർ കയറണ്ട എന്നാണ് ലാസ്റ്റ് വേർഡ്. അപ്പൊ ഈ ഒരു കാര്യത്തിന്റെ അകത്ത് തമാശക്കുള്ള കാര്യമില്ല. സീരിയസ് ആയിട്ട് നിൽക്കുന്ന ആൾക്കാർ കാര്യാ മതി, അല്ലാത്തോട്ട് വരണ്ട. ദാസേ, താങ്ക് യു.
Thank you.
Good night.